Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is heart disease in pregnancy, and specially we will focus on classifications of heart disease in pregnancy. What are the cardiovascular system physiological changes in pregnancy is a commonly asked question. If you get a case in your practical examination for the postgraduates, or if you get a theory question, and also in basics first paper, this is a commonly asked question: CVS changes, cardiovascular system changes. So related to heart, the main thing is there is a shifting of the apex to the left, and the heart is itself rotates on the left long axis and deviates to the left. There is a physiological pericardial effusion. What is most important, and as a terminology which should always be, you should be using whenever we are discussing physiological changes, is ventricular remodeling. That means the ventricle is getting geared up with the changes in the ventricular structure to accommodate the changes which are taking place, increasing the work of the heart, increasing the cardiac work. So that terminology which is important and which is commonly used is ventricular remodeling. What is happening in ventricular remodeling is left ventricle mass expansion is by 30% by term pregnancy. So there is an increase in left ventricular mass, and the increase is by 30%, and this is called as the ventricular remodeling, which is characteristically seen in a normal pregnancy, that the heart is getting changed. Not only the apex is shifting to the left, but even the ventricles are also, there is an increase in left ventricle mass. Now there are hemodynamic changes in pregnancy, so that there is increase in blood volume by around 40%, and preload increases. With the increasing blood volume, there will be increasing preload, but ejection fraction remains normal. That is most important concept I want students to focus on is, in spite of increase in the preload, ejection fraction is remaining normal. So what is this ejection fraction exactly? It is the percentage of the blood which is present in the heart being thrown out with each heartbeat. During contraction, whatever is the amount of blood is present in the heart, out of which how much is getting thrown out into the systemic circulation with each heartbeat, that is ejection fraction. Now, if it is less than 40%, that means less than 40% of the blood is getting ejected out of the heart, or from the left ventricle to the aorta, less than 40% is being ejected out with the heartbeat, then it indicates a poor heart function. Normal ejection fraction is 55 to 70%. So what we have seen here is there is increase in the preload, but ejection fraction remains normal. In spite of more blood being present in the heart, that doesn't mean that it remains for a greater time in the heart. With each heartbeat, the amount of blood which is being thrown out, the percentage of the blood which is being thrown out into the systemic circulation is same as in non-pregnant women. Cardiac output increases from 5th week of pregnancy itself. This is because of the fall in systemic vascular resistance and rise in heart rate. Heart rate increases by around 10 beats per minute during pregnancy. And these changes are seen as early as 5th week of pregnancy, leading to initiation of increase in the cardiac output. Cardiac output is maximum in left lateral position. As obstetricians, always we are telling the pregnant woman to lie in a lateral position rather than in the supine, and that too in the left lateral as compared to the right lateral. In the left lateral position, there is maximum cardiac output, so placental perfusion will be maximum. It is less in supine position, cardiac output, and the cardiac output is least in standing position. Cardiac output corresponds with fetal oxygen saturation, and that is how we see that, especially whenever we diagnose a case as intrauterine growth restriction, as a part of treatment we ask the pregnant woman to lie in the left lateral position with the hope that that will improve the fetal oxygen saturation and that will improve the fetal growth. Now with increasing preload, ejection fraction remains normal. So in nutshell, cardiac function remains normal in a normal pregnant woman, and that is why it is called as a eudynamic heart. During pregnancy, the heart is functioning normally. That is why it is called as a eudynamic heart. So these are certain terminologies which we should be using whenever we are asked about the serious changes during pregnancy, physiological changes. So one is ventricular remodeling, another is changes in the cardiac output as per the positioning of the pregnant woman, and third is how the heart function is eudynamic or normal, how the ejection fraction remains normal. Now the ventricular remodeling which takes place is concentric ventricular remodeling. Now suppose this is the normal left ventricle, this is the left ventricle during pregnancy. As we can see, there is an increase in the mass. Left ventricle mass expansion is by 30%, and that is how because of this change in the left ventricular remodeling or change in left ventricle, the heart can throughout the increased amount of the blood into the circulation with the increasing preload, ultimately leading to a normal cardiac function. Why preload increases? It is because of the increasing blood volume during pregnancy. And there is a left ventricular remodeling leading to normal cardiac function. Cardiac output increases, and the two reasons for that are fall in peripheral vascular resistance and increase in heart rate. So this is about preload, this is about the afterload or cardiac output, and this is about the heart function. Heart function remains absolutely normal in spite of hemodynamic changes which are seen during pregnancy and in spite of changes in peripheral vascular resistance and heart rate. If we can remember the cardiac CVS changes like this, what is increasing is cardiac output by 30%, heart rate increases by 10 to 20%, ventricular mass, especially left ventricular mass, is also increasing by 30%. There is a increase in the preload because of increasing blood volume. Blood volume is increasing by 40 to 45%. There is increased femoral venous pressure in supine position because of the compression of the inferior vena cava by the gravid uterus in second half of pregnancy. There is a fall in peripheral vascular resistance, there is a fall in pulmonary vascular resistance, and there is associated fall in systolic and diastolic blood pressure, which is more pronounced in supine position. And if we compare this, greater fall in diastolic blood pressure as compared to the systolic blood pressure. There is a normal cardiac function, though cardiac work increases by 25%. That means if whenever a patient has no cardiac disease, no heart disease, the body changes do take place. That though the heart work increases, cardiac work increases by 20%, the ultimate cardiac function remains normal in a normal woman with no cardiac disease. Changes in labor, there is further increase in the cardiac output during labor. Moderate increase is seen in first stage of labor, and significant increase in cardiac output will be in the second stage of labor. There intrapartum blood loss is there around 400 ml in normal delivery and approximately 800 ml on an average in cesarean section. Post delivery, there is immediately after the delivery, there is sudden increase in the preload, and this increase in the preload is because of the decompression of inferior vena cava as well as the blood which is getting thrown into the general circulation from the uteroplacental bed. So there is an auto transfusion from the uterus, and which remains there for 24 to 72 hours. So that is how more blood is getting into the circulation. With each uterine contraction, 500 ml of the blood is getting added to the general circulation, and that is the reason why there is increase in the cardiac output, and the output increases by 50%, around 50% in second stage of labor. Now, why heart disease is difficult to diagnose in pregnancy is a question which we are usually which is being asked even to undergraduates also. So the symptoms which do mimic like heart disease in a normal pregnancy are there is breathlessness on exertion, there is a easy fatigability or exhaustion, palpitation on exertion, and patient gives history of pedal edema also. On examination, there is a split in first heart sound in a normal pregnancy. Heart sound is louder, and with the split, both the components are louder. Systolic murmur is seen with the physiological changes of pregnancy with the hemodynamic changes. Third heart sound can also be heard. Continuous mammary murmurs are heard, which are sometimes which lead to the confusion about whether there is a heart disease in the patient, and presence of pedal edema. All these features make it is difficult for a clinician to diagnose heart disease during pregnancy. On investigation, X-ray just shows cardiomegaly, and the two reasons for cardiomegaly are because of the left shift of the effects of the heart, as well as because of the presence of benign pericardial effusion. ECG is indicative of a left axis deviation during pregnancy, and with all these changes, it becomes more difficult to diagnose heart disease. It is a challenge to diagnose heart disease during pregnancy. Now, what are the high risk periods for congestive heart failure in pregnancy, and why these are the high risk periods during pregnancy? The first, the possibility of patient going in failure or change in the patient's risk of having going from low risk to the high risk. Patient suddenly can change, the patient's condition can change whenever patient has a heart disease. From 12 to 16 weeks is the first time when the hemodynamic changes are significantly uh, initiating to have a effect on the heart. 12 to 16 weeks. Next period is 28 to 32 weeks. In this period again, there is a why, because there is a peak in the hemodynamic changes. After that, the hemodynamic changes, there is a plateau which is seen. But here, heart is, if not able to cope up with the peak, then this is the risk period when patient can have a heart failure whenever there is a heart disease complicating pregnancy. Then in labor, first stage of labor, there is increased preload by 300 to 500 ml, which is entering into the circulation from uteroplacental bed with each contraction. Now, second stage, sometimes there is an increase in cardiac output, as we have seen in the previous slide, but sometimes there is a sudden fall in cardiac output also can occur because of the severe compression of the contracting uterus over the inferior vena cava, reducing the venous return. So that is how the cardiac output keeps on changing in the second and first stage of labor, and that adds to the burden over the heart. And that is because of the changes in the cardiac output. Labor is another period when patient can go in failure. Immediately after delivery, as we have seen in the previous slide, sudden increase in the preload is there because the compression over the inferior vena cava is taken away with the delivery of the baby. So that increases the venous return, and from uteroplacental bed also the blood is getting placental bed is getting squeezed, and that is how the blood is entering into the general circulation. Last is 4 to 5 days postpartum. Then there is a risk of pulmonary embolism in women with heart disease, and secondly, especially whenever there is a low output heart disease, such as with aortic stenosis, because of the peripheral blood pooling in after delivery. This after 4 to 5 days after delivery, patient can go in failure. So patient with aortic disease can go through pregnancy, labor without sometimes without any complication, but postpartum 4 to 5 days after delivery, patient can suddenly go into cardiac failure. So that is how graphically we can see how the what are, this is a very favorite question which is asked. What are the risk periods and when do you expect a patient with heart disease to show worsening of the condition or to go into failure? So these are the typical periods when we get majority. Any time patient can go in failure. It depends on what is the baseline condition. But these are the risk periods because of the changes which are taking place into the hemodynamic circulation during these periods, making the pregnant woman more prone to go in failure during these 5 periods. What are the fetal and neonatal effects of heart disease in pregnancy? With the ischemic heart disease. Now, more and more women are even getting ischemic heart disease with increasing age of the woman going for pregnancy. With that, there is a 16% risk of small for gestational age baby. Chronic hypoxia, if it is there during in a case of heart disease, patient is going into failure, that can lead to small for gestational age babies. Prematurity is also sometimes seen with the heart disease, and overall there is increase in perinatal morbidity and mortality. Another cause is there is an increased risk of congenital heart disease whenever in the baby, whenever mother has congenital heart disease. So that also adds to the this burden over the perinatal morbidity and mortality. What is the clinical classification of heart disease in pregnancy? If you are asked this question, remember that there is only one clinical classification, that is NYHA, New York Heart Association classification. It was introduced way back in 1956, but it is used more and more commonly in clinical practice since last few decades. It assesses current functional capacity of the heart. It assesses present clinical status. It is easy to implement. These are the advantages of this classification, that it gives us the idea about what is the current status of the pregnant woman, how is the functional capacity of the heart. That is why it is also called as functional classification or clinical classification. Its disadvantages are it is not helpful for prognosis. It doesn't give us the idea how the patient will go through the pregnancy or puerperium based on this classification. It is a subjective way of classifying a woman because it is based on symptoms. So we are here entirely dependent on how reliable patient's history is, and it doesn't give any importance to science or investigations or to underlying heart disease. Now here class 1 is, this is how I remember. ALOA is easy to remember. No limitation of activity in class 1. Class 2, there is slight limitation of activity, but patient woman is good at rest. But with ordinary activity also symptoms do arise, such as breathlessness, palpitation. These symptoms will be seen with the ordinary activity. Class 3 means there is a marked limitation of activity and the symptoms are seen with less than ordinary activity. So this is how you should remember that class 2 is with ordinary activity symptoms are appearing, and class 3 is less than ordinary activity also patient cannot tolerate, and symptoms are seen with the less than ordinary activity also. Whereas class 4 is severe limitation of activity, where even at rest also a woman can be symptomatic. How do you predict prognosis in a case of heart disease complicating pregnancy? So this question is the main topic which we are discussing today, is about the various classifications which are prognostic classifications. Clinical classification gives us the idea about the current state, NYH classification, but it fails to tell us about the prognosis, and that is why it is not a predictive classification. So if we are asked about the prognosis classifications which help us in prognosis, we have this prognostic classification. CARPREG 1. CARPREG, how you remember? CAR is for cardiac and PREG is for pregnancy. CARPREG 1, that is it was most commonly used in the past because of the ease of its implementation. Then there was CARPREG 2 and Zahara, and WHO risk classification was also introduced way back in 1958. But what is currently been used most in all the, if you see the references in the current literature, the classification which is used as a prognostic classification for heart disease in complicating pregnancy is modified WHO risk classification 2018. This modified WHO risk classification of cardiovascular disease and pregnancy 2018 has been modified by European Society of Cardiology. ESC. It was modified and it was introduced in 2018, and it is the classification which has greatest predictive accuracy. If we compare all this classification, this is the best because it has greatest predictive accuracy. This is modified WHO risk classification of cardiovascular disease, and pregnancy is the complete name, but we can, in short, we can say modified WHO classification. And it was modified by European Society of Cardiology. It is because of its good predictive accuracy, it forms important part of preconceptional counseling. Suppose a woman comes to us with a heart disease complicating pregnancy, and she is asking us whether she can take a chance, whether she can go ahead with planning a pregnancy, and how is the risk, and what is the prognosis. For such a counseling, this classification helps us a lot. It clearly, another advantage of this classification is it clearly provides contraindications for pregnancy, or in other words, it gives us clear-cut indications to consider medical termination of pregnancy if a patient conceives in those conditions. It gives consideration not only for science or investigations, it also gives consideration for underlying heart disease. So these are the advantages of this classification, because of which it has a, and most important advantage is it has a greatest predictive accuracy. Again, it is important to remember NYHA is not a predictive classification. What is Carpeg 1 classification? As I said, it was the classification which was used quite frequently in the past. There are only four parameters are there. 1 point is given to each parameter. Risk of cardiovascular complications in pregnancy is called as Carpeg risk score. So this score is how much is the risk of a patient of having cardiovascular complications during pregnancy. 0 point, the risk is 5%. 1 point, risk is 27%. You can remember around 25%, and greater than 1 point, that means 2 or more than 2, then the risk of complications increases to 75%. It was popular because of the ease of implementation, but now it has been replaced by a better modified WHO system. What are the four parameters which were considered in Carpeg 1 classification? First was prior cardiac event, such as patient has a history of ICU admission, heart failure, pulmonary edema, and requiring intensive care. All those were considered under prior cardiac event. Second is NYHA grade 3, grade 4, or patient is having cyanosis. Grade 3, grade 4, grade 3 is patient is having symptoms with the less than ordinary activity also. And grade 4 is patient can be symptomatic even at rest. Left heart obstruction, such as mitral stenosis with the area less than 2 centimeters square and aortic area less than 1.5 centimeters square. That was the third. And fourth, ejection fraction less than 40%. So that is how it was. We can appreciate that it is easy to implement, but it is not giving importance to many conditions which are now emerging with the better treatment options also, and that is how it has been replaced now by modified WHO system. If we are asked what are the contraindications for pregnancy, what are the in which situations pregnancy is contraindicated in a case of heart disease, or what are the indications for medical termination of pregnancy in a case of heart disease complicating pregnancy, or what are the class 4 as per modified WHO classification. So these are the three questions and answer will be same. And why these are contraindicated? If we are asked this question, so that means, in other words, we are first focusing or discussing class 4 of modified WHO classification. And I think that if we start with this, that we first understand the conditions which are absolute contraindications for pregnancy, it makes us easier to understand class 3 compared to this class 4, and then shifting to class 2 and class 1 where the pregnancy is having no greater risk than a non patient without any heart disease. So first we will see what is class 4. First is pulmonary hypertension. Second is severe systemic ventricular dysfunction. Systemic is whatever ventricle is throwing blood into the general circulation, and unless there is a rare congenital malformation, it will always be the left ventricle. So severe left ventricular dysfunction, where it will, how we will know there is a severe left ventricular dysfunction? Either NYHA 3 or 4 class will be there, or if we do echo, then left ventricular ejection fraction will be less than 30%. Then it becomes class 4. Previous peripartum cardiomyopathy with residual left ventricle dysfunction. That means patient gives history of peripartum cardiomyopathy, and there is persistence of some left ventricular dysfunction. Residual dysfunction is there after delivery also, after 3 months of delivery also, then that will come to class 4, where pregnancy will be contraindicated, or there will be it will be an indication for medical termination of pregnancy because of the high risk of maternal morbidity as well as mortality. Fourth is severe left heart obstruction, where there is severe mitral stenosis or there is severe and symptomatic aortic stenosis. Fifth is Marfan syndrome with aortic root dilatation of greater than 45 millimeters. Sixth is aortic dilatation greater than 50 millimeter in aortic disease with bicuspid aortic valve, especially. Normally the aortic valve is tricuspid, and if it is bicuspid, and with that if dilatation is greater than 50 millimeter, then it comes under this class 4. Severe coarctation of aorta, that comes under class 4. Fontan procedure with residual complications. Now if we read this classification and we just read all these conditions, it is sometimes it becomes very difficult to memorize this because these conditions, because we fail to understand what exactly is happening with these conditions, and that is why we cannot answer this question why. And to answer this question, now we will see each condition one by one. What is happening in pulmonary hypertension? Heart is not able to compensate for physiological changes in pregnancy with the pulmonary hypertension. It is associated with severe morbidity and high mortality. Now, diagrammatically, as we can see here, because there is a increased resistance to the pulmonary circulation. As you can see, this is the normal pulmonary artery. Pulmonary artery carries blood from right ventricle to the lungs. It carries deoxygenated blood from right ventricle to the lungs, and as the blood gets oxygenated, pulmonary vein is draining the oxygenated blood into left atrium. So here there is increase in the pulmonary vascular resistance. That means there is pulmonary hypertension, and there are so many conditions which lead to pulmonary hypertension, such as there can be a primary pulmonary hypertension, or it can be secondary to severe mitral stenosis also. So whatever is the reason, if there is pulmonary hypertension, the pulmonary artery has got a smaller capacity. As we can see here, the capacity is less, so right ventricle is not able to push the blood into the pulmonary circulation the same extent as it should be doing in a normal patient. Because of this increasing force which is required to push the blood into pulmonary circulation, there is a right ventricular hypertrophy, and because of that, ultimately there is a right heart failure in these patients. So there is an increase in afterload. That means the right ventricle is facing problem to push the blood into the pulmonary circulation, leading to right ventricular hypertrophy and right heart failure. And that is why pulmonary hypertension is #1 cause for high maternal morbidity and mortality, and that is why it is considered as a contraindication for pregnancy or indication for medical termination of pregnancy. Second is severe systemic ventricular dysfunction. As I said, systemic means whichever ventricle is throwing blood into the system or general systemic circulation. So it is always the left ventricle, unless there is a congenital malformation where left ventricle is not developed and there is a small left-sided heart, then only right ventricle takes over the role of a systemic ventricle. Otherwise, whenever we say systemic ventricular dysfunction, it is almost synonymous with left ventricular dysfunction. Heart is not able to pump the blood effectively in these cases. So whatever total blood is present in the left ventricle, how much the heart is able to pump out with each heartbeat, that or how much is getting ejected during systole, that is ejection fraction. And if the blood which is getting pumped out is less than 30%, that means left ventricular ejection fraction is less than 30%. So if ejection fraction is less than 30%, it is indicative of this severe systemic ventricular dysfunction. Or secondly, if patient has NYHA class 3 or class 4, that means symptoms with less than ordinary activity or symptoms at rest, that is class 4, then also it is indicative of a heart failure or systemic ventricular dysfunction which is severe. And if it is present like this, unless the patient comes out of it or there is an improvement, she should not plan a pregnancy, or she conceives with these findings, then we should consider an option of medical termination of pregnancy. Third is peripartum cardiomyopathy with residual left ventricular dysfunction. Heart failure is seen in some women in third trimester towards especially last 1 month of pregnancy, or up to 5 months postpartum because of this peripartum cardiomyopathy. With this peripartum cardiomyopathy, there is a weakening of heart with dilatation of left atrium and left ventricle. As this is the normal heart, what is happening with peripartum cardiomyopathy is there is a dilatation cardiomyopathy. So there is a dilatation of left atrial and as well as dilatation of left ventricle. Both are dilated. Now about 50% recover completely by 1 year after delivery, but in remaining 50% there is a residual left ventricular dysfunction and patient remains symptomatic and needs ongoing treatment in around 50% of the women having peripartum cardiomyopathy, and these are the women where pregnancy will be associated with a high risk of mortality and morbidity, and so pregnancy will be contraindicated. Fourth contraindication for the pregnancy is severe left-sided obstruction, where we have mitral stenosis severe, where the area is less than 1 square centimeter, and second is aortic stenosis, which is severe as well as symptomatic. What is happening with mitral stenosis is because the blood is not flowing freely from left atrium to the left ventricle, then it leads to left atrial dilatation. With left atrial dilatation, there is a atrial fibrillation can occur, and that will lead to the worsening of the patient, or it will lead to increase in the pulmonary vascular bed resistance will increase, leading to pulmonary hypertension as a serious complication. It also leads to fixed cardiac output because the less blood is entering from left atrium to left ventricle. By echocardiography, we measure the area of the mitral valve, and normally it is greater than 4 square centimeters. Mild mitral stenosis is when it is between 1.5 to 2.5 square centimeters. Moderate is 1 to 1.5 square centimeter, and severe is whenever it is less than 1 square centimeter, where it is associated with very high maternal morbidity, mortality, and leading to especially considered as a contraindication for pregnancy. Heart failure will occur whenever there will be increasing preload or whenever there will be tachycardia during pregnancy. In aortic stenosis, here the from left ventricle the blood is getting pushed into the aorta through the aortic valve. So if there is a resistance here, aortic stenosis is there at the aortic wall, it leads to left ventricular hypertrophy. It will lead to whenever there is a decrease in the preload. That means with obstetric hemorrhage, anytime patient bleeds, the preload will be less. Or if patient is being given regional anesthesia, that will lead to sudden hypotension and fall in the preload. So whenever the preload reduces, it leads to heart failure because already the cardiac output is less in this condition. So this is a condition where there is a pregnancy change of increasing cardiac output is not seen. On the other hand, cardiac output is less because of the severe and symptomatic aortic stenosis, and with that, if there is any time there is a reduction in the venous return, there is a reduction in the preload because of any reason, that will be the time when patient will go in heart failure with the severe and symptomatic aortic stenosis, and that is why it will be difficult to treat, also leading to high maternal mortality. Severe aortic dilatation or dilation. Severe aortic dilation, two conditions are there where it will be associated either with Marfan syndrome or with any other condition leading to aortic disease. With Marfan syndrome, whenever aortic dilatation is greater than 4.5 centimeters, it is considered as a contraindication for pregnancy. And without Marfan syndrome, any other condition which also can lead to aortic disease and it is greater than 5 centimeters, and especially if it is associated with bicuspid aortic valve, which is seen congenitally in some patients. In these women, why pregnancy is contraindicated is there is a high risk of aortic dissection. And with the aortic dissection, there can be a hemorrhagic pericardial effusion will occur, and patient ultimately will have a difficult time and high chances of maternal morbidity, mortality will be there. Patient will go in failure, high risk of failure will be there whenever the dilatation is greater than 4.5 centimeters. Normal aortic root is 2 centimeters. Greater than 4.5 centimeters indicates severe dilatation. Pregnancy complications are aortic dissection and heart failure because of aortic insufficiency. Because of these two complications, aortic dissection can occur, blood can seep from the thin aortic wall outside the aorta, or there can occur a heart failure because of associated aortic insufficiency. The opposite of this dilatation is severe aortic coarctation. Coarctation is narrowing. Narrowing of aorta, it is a rare congenital heart disease. Severe coarctation is when it is less than 15 millimeter. Area is less than 15 millimeter. It is considered as severe aortic coarctation. This is the aortic arch, and this is the place where there will be a narrowing, congenital narrowing of the aorta. Here, heart failure is because of associated chronic hypertension. Infective endocarditis with bicuspid aortic valve can occur. Bicuspid aortic valve is associated congenital malformation in these cases. And aortic rupture can occur because of this force of the blood which is going through here, and there is a sudden constriction. Aortic rupture can occur, and that can lead to higher chances of maternal morbidity as well as serious morbidity and maternal mortality. Last is Fontan procedure with residual disease. Now what is happening? What is happening here is there is a hypoplastic left heart. Left atrium, left ventricle are not well developed. Single functional ventricle, that is the right ventricle, is a single functional ventricle here. So what is happening here is only right ventricle is acting as right as well as left ventricle, and it cannot then function properly. So here what is done to overcome this problem is a surgical anastomosis is created between vena cava and pulmonary artery. So the deoxygenated blood, rather than going to the right atrium, right ventricle, and then entering into the pulmonary circulation, the blood is deoxygenated blood from vena cava directly enters into the pulmonary arteries and goes to the lungs. Once it gets oxygenated through pulmonary vein, it will be entering into the this hypoplastic left atrium, and with a created opening like a atrial septal defect, an opening is created through which now blood will enter to the right side, right atrium, right ventricle, and aorta will be aortic opening will be here at the this ventricle, and that is how right ventricle, and that is how blood will enter from right ventricle into the systemic circulation. This is called as Fontan procedure, where main thing is connecting the vena cava circulation, the vena cava with the superior and inferior vena cava with the pulmonary artery. So it will bypass the right ventricle. Now, what happens here is with this left hypoplastic left heart, whenever Fontan procedure is done and if there is a residual disease is present, patient will not be able to tolerate changes in preload, heart failure and arrhythmias will occur. Miscarriages and preterm births are also very commonly seen because of the persistent hypoxic condition, and that is why this whenever there is a hypoplastic left heart, though Fontan procedure is done, if it is associated with residual disease, it is a contraindication for pregnancy. So what you remember is hypoplastic left heart, and the procedure which is done is anastomosis between the vena cava and pulmonary artery. And if there is a persistence of disease, residual disease is present, it is a contraindication for pregnancy. Now next part of this modified WHO classification is class 1. So what are the conditions where heart disease carries no additional risk? The risk is same as in a woman without heart disease, in other words. So that is class 1. If you are asked what are the conditions where the risk to the mother or the baby both is same as the woman without heart disease, your answer is you are answering class 1 of WHO classification. So first is mild pulmonary stenosis. It is a now we have seen that if there is a mitral stenosis, aortic stenosis, it's whenever it is severe, it is a contraindication for pregnancy. But on the other hand, if there is a mild pulmonary stenosis, where there is some resistance to the flow of the blood from right ventricle entering into the pulmonary artery, it carries no additional burden. It doesn't pose additional complications during pregnancy, and that is why it comes under class 1. Second is if there is a mild patent ductus arteriosus. Ductus arteriosus is the connection between this pulmonary artery and aorta. And if it remains persistent, but it is mild patent ductus arteriosus, then these cases also there is no additional risk of complication to the mother or baby, and it comes under class 1. Or mild mitral valve prolapse. If there is with trivial mitral regurgitation, mitral valve prolapse with trivial mitral regurgitation, then also there is no additional risk to the mother or baby. So all these three mild we have: mild pulmonary stenosis, mild patent ductus arteriosus, mild mitral valve prolapse. Next group in this class 1 modified WHO class 1 classification is in class 1 is successfully repaired simple lesions such as ASD, atrial septal defect. It is called as ostium secundum atrial septal defect, where there is a defect in the center of this atrial septum. Then it is called as ostium secundum, which has a good prognosis. So if it is repaired successfully, or a repaired VSD, or repaired patent ductus arteriosus, all that. Fourth is repaired if there is a total anomalous pulmonary venous drainage. It is called as a TAPVD, total anomalous pulmonary venous drainage. What is happening here is this is the pulmonary vein which normally should drain into the left atrium, but it fails to drain here. So if the surgically this is being corrected, the connection between pulmonary vein and left atrium is created surgically, so that there is no mixed blood going to the heart. Then these are the cases where prognosis is very good. So these are the successfully repaired simple lesions: ASD, VSD, PDA, and this total anomalous pulmonary venous drainage. drainage. All this belong to class 1. No additional risk to the maternal life. And if there are isolated ventricular extrasystoles or atrial ectopic beats, then also there is no additional risk to the mother's life, and that is why it comes under class 1. So 1, 2, 3 are mild pulmonary stenosis, patent ductus arteriosus, mitral valve prolapse. 4 are surgically corrected simple lesions, ASD, VSD, PDA, and TAP, VD. And last is isolated extrasystoles or ectopic beats. This is how we can remember class 1. Uncomplicated, mild or simple pulmonary stenosis, patent ductus arteriosus, mitral valve prolapse, surgically corrected simple lesions, ASD, VSD, PDA or TAPVC, and isolated ventricular extrasystoles or atrial ectopic beats. I have remembered it this way. You can also have your own way, but it is easy to remember that way, that 3 mild lesions, 4 surgically corrected simple lesions, and 1 is about the ectopic beats. Now, what is class 3? Now we will come after class. We have seen class 4, we have seen class 1. After that, we are now coming to class 3. The reason why I have designed this uh, our discussion in this way is mainly because there are so many conditions which are similar between class 4 and class 3. In class 4, suppose a lesion is very severe, here it will be, severity will be slightly less. Whatever are in black colors are the similar conditions which are present in class 4 as well as class 3, and red are the one which are not similar with each other. So we have already seen class 4, pulmonary hypertension, which is not seen in class 3, but severe systemic ventricular dysfunction, left-sided ventricular dysfunction where ejection fraction less than 30% or NYHA 3 or 4, we have already seen it is a contraindication for pregnancy. So it is severe. Whereas here in class 3, we have moderate left ventricle impairment. So if you remember this way, it becomes easier. Otherwise, it is very, very difficult to uh, memorize this WHO modified WHO classification and reproduce it. But if you remember this way, there is some connection, horizontal connection, it becomes easier for us to remember. Peripartum cardiomyopathy with residual disease we have seen is in class 4. Without residual disease is in class 3. If there is a severe MS, it is mitral stenosis, it is class 4. If it is moderate, it is class 3. Severe and symptomatic atrial stenosis is class 4. Severe and asymptomatic atrial stenosis is class 3. Severe aortic dilation is class 4, whereas moderate aortic dilation with 40 to 50 mm is the dilation of the aorta, that comes in class 3. Quantum procedure with residual disease is in class 4. So quantum procedure without residual disease comes to class 3. That is how you can remember that at least these 1, 2, 3, 4, 5 and 6 conditions we can remember like that for class 3. Others are presence of mechanical valve. Whenever mechanical valve is there, it also has a it poses a risk to the mother, but it is not a contraindication for pregnancy. That is the difference between class 4 and class 3. Though the chances of maternal morbidity are great, mortality is also significant, but it is manageable. Pregnancy is not absolutely contraindicated. That is the difference between class 4 and class 3. So presence of mechanical valve, it is class 3. Systemic right ventricle, that means whenever there is a right ventricular failure, it is class 3. Complex congenital heart diseases is class 3, and congenital heart disease associated with cyanosis. Cyanotic heart disease is also class 3, and ventricular tachycardia is class 3. So if we remember this way, these 6 conditions related to class 4 and remaining are 2-3 conditions which are peculiar for class 3. It becomes easier to remember this class 3 of this modified WHO risk system. What is class 2 and what is class 2/3? that leads to additional confusion in this classification, and it becomes sometimes we feel that it is becoming more and more difficult to remember. But to make it easier, remember that there are only 4 conditions in class 2. And class 2/3 is, what is the meaning is, it the class will change as per individual findings in that case. Some, that means there is a range. For example, suppose we take hypertrophic obstructive cardiomyopathy. Some patients will behave like class 2, some will behave like class 3. That is the meaning of this class 2/3. In class 2, this is green color means still the chance risk to the mother's life are less. That is why I have selected this green color. And there are only 4 conditions. Unoperated ASD, VSD. There is a slight increase in the mortality and moderate increase in morbidity. But still it is comparatively pregnancy is not very unsafe, and that is why it is class 2. Operated phallic tetralogy is class 2. Most arrhythmias come to class 2, and whenever there is a Turner syndrome but there is no associated aortic dilatation or dilation, that comes to class 2. So if you remember this 4, your class 2 is over. Class 2/3 is HOCM, hypertrophied obstructive cardiomyopathy. Mild left ventricular impairment is this class 2/3. Repaired coarctation of aorta, prior heart transplantation, Marfan syndrome with no aortic dilation, and congenital heart disease which is not belonging to either category 1 or category 4 will come to this class 2/3. How do you interpret WHO, modified WHO classification or these classes is? And accordingly how you take action is, if it is class 1, there is no increase in morbidity or mortality because of the heart disease. Maternal morbidity mortality is same as in women without heart disease. That is the information we gain, and these women can be managed in local hospitals. Class 2 is, there is a moderate increase in morbidity and there is a small increase in mortality, but still these can be managed at the local hospitals only. Class 2/3 is, there is moderate to severe increase in morbidity and intermediate increase in mortality, and these are better managed at referral centers where the cardiologists will also be available. Whereas multidisciplinary management will be required for class 3, class 4, where there is a severe increase in morbidity in class 3, significant increase in mortality in class 3, and in class 4, very high risk of severe morbidity, very high risk of maternal mortality, and these 3 and 4 both to be managed at tertiary care. That is how, if you are asked how do you interpret or how it helps, this modified WHO classification is, it helps us for prognosis, how much is the risk of maternal morbidity, mortality, as well as it gives us the idea at what setup the patient can be managed. What are the indications to refer the patient to higher center or to manage the patient at tertiary care hospital? Again, to make it simpler horizontally, I have created this slide, WHO's stratification, to show again the similarities. Class 1 and class 2, we have repaired ASD, VSD in class 1, whereas unrepaired ASD, VSD is there in class 2. Along with ASD, VSD, we have repaired Fallot tetralogy also in class 2. Here we have repaired ASD, VSD, PDA, and this total anomalous pulmonary venous circulation is also there. Then small or mild patent ductus arteriosus, mitral valve prolapse, pulmonary stenosis, that is class 1, and extrasystole atrial ectopixis class 1. Class 2, apart from this unrepaired ASD, VSD, we have repaired Fallot tetralogy in class 2. Turner without aortic dilation is in class 2, and most arrhythmias belong to class 2. Class 2/3 is midway between this safe disease and unsafe very unsafe situation, and that is why like traffic signal we can remember green for class 1 class 2, and this orange for class 2 oblique 3, and red for class 3 and class 4. So class 2 oblique 3 we have mild left ventricular dysfunction has started here. So mild is in class 2 oblique 3, moderate is belongs to class 3, and severe belongs to class 4. So horizontally you can remember like that. Left ventricular dysfunction, mild starts in class 2 oblique 3, moderate for class 3 and severe for class 4. Similarly, cardiomyopathy, hypertrophic cardiomyopathy will be class 2 oblique 3. But peripartum cardiomyopathy jumps to class 3 with no residual disease, and with residual disease it goes to class 4 with a contraindication for pregnancy. Moderate MS class 3, severe MS mitral stenosis class 4. Severe and asymptomatic aortic stenosis class 3, whereas symptomatic and severe aortic stenosis class 4. So like this we can remember also. Quantum no residual disease is class 3, with residual disease will be class 4. Moderate aortic dilation class 3, severe aortic dilation will be class 4. Then what else is additional here is there is a unrepaired cyanotic congenital heart disease is class 3. Ventricular tachycardia is class 3, and mechanical valve is also class 3, and any complex congenital heart disease also class 3. Like that we can remember the various conditions. Severe coarctation of aorta will go to class 4. Class 1, class 2 also we can remember horizontally, and this class 2 oblique 3, class 3 and class 4 also we can remember like this horizontally. Here we have Turner without aortic dilatation for class 2. Here we have Marfan without aortic dilation in class 2 oblique 3, and repaired coarctation comes to class 2 oblique 3. Whereas if it is unrepaired and severe coarctation, that will go to class 4. Again, diagrammatically, again to repeat the same thing, because I want to make the classification as easy as possible for you to memorize and reproduce. So class 1 is yellow area, I have shown it here, where it is the operated ASD, operated VSD. Here it is operated this patent ductus arteriosus, and this is the operated this total anomalous pulmonary venous drainage. So 1, 2, 3, 4. All these yellow areas are operated. Whereas red are mild mitral valve prolapse, mild PDA, for presence of patent ductus arteriosus if it is mild, or if there is a mild pulmonary stenosis or extrasystole ectopic beats. Like that, diagrammatically we can remember. This is blue one is the pulmonary this artery which is carrying the deoxygenated blood from this right ventricle, and mild pulmonary stenosis comes under class 1. Class 2, unrepaired ASD VSD, red areas. Unrepaired ASD VSD, but it is uncomplicated. So these are class 2. Slightly increased risk is there, but still pregnancy is relatively safer. Repaired Fallot tetralogy. Fallot is where there is a VSD, where there is a pulmonary stenosis along with VSD, along with overriding of the aorta with right ventricular hypertrophy. All these are taken care of surgically, then it is repaired Fallots. That will come under class 2. Most arrhythmias come under class 2, and Turner with no aortic dilation will come under class 2. Class 2 oblique 3, where there is a range depending on individual findings, either the patient can shift to T2 or patient can go to 3. So here, as we can see here, there is a hypertrophic obstructive cardiomyopathy. So hypertrophy of the left ventricle and area of the left ventricle is reduced, and significant reduction will lead to class 3 and less significant will lead to class 2. So HOCM is first. Second is mild left ventricular dysfunction, which was till now left ventricle is functioning normally, class 1, class 2. And left ventricle dysfunction is starting in class 2/3. So mild left ventricle dysfunction, HOCM, Marfan with no aortic dilation and repaired coarctation of aorta. All these four are coming in 2/3. What is in class 3 is now there is a significant change to the left side of the heart. Moderate mitral stenosis, asymptomatic and severe aortic stenosis, moderate left ventricular dysfunction. Red, I have shown the left ventricle as red. Then peripartum cardiomyopathy, I am showing it as the left-sided heart getting dilated with the peripartum cardiomyopathy, but with no residual disease. Mechanical presence of mechanical valve, ventricular tachycardia, and aortic dilation. Aortic dilation, I have shown it as purple, which is between 40 to 50 millimeters. So I have tried to diagrammatically include major conditions which will come under class 3. Class 4 is almost the same except the severity is increasing. Severe mitral stenosis, severe and symptomatic aortic stenosis, severe coarctation. Here we can see severe coarctation of aorta, severe aortic dilation, that will also be there. And anytime there is a pulmonary hypertension, then also it is class 4. And peripartum cardiomyopathy with residual disease, left ventricular dysfunction, which is severe. Anytime severe left ventricular dysfunction, that will come under class 4. I hope that this diagrammatic representation makes it easier that we can see that left ventricle is functioning normally in class 1, class 2. Some dysfunction here, moderate dysfunction here and severe dysfunction here. So left-sided heart dysfunction is all mainly going for this from 2/3 to 3 and then to class 4. And especially the involvement of aorta, either aortic dilatation or coarctation. Both are going for class 3 and class 4. That is how we can remember horizontally how the class is changing. Initially, though, we can find the classification complex if you know the reasoning why this condition is going to this class. Such as mechanical valve, we know that the chances of thromboembolism are so high, and we need to do the give anticoagulation, and still the risk will be more. Even the treatment itself can lead to some complications, and that is why it comes to class 3. Peripartum cardiomyopathy, heart is getting so weakened, and that is why previous history of peripartum cardiomyopathy without residual disease also will go to class 3. If we know the reasoning like this, if we understand the conditions, then it becomes easier for us to remember also. We don't have to memorize too much in that case. What I mean to say is, if we understand that from class 2/3 serious conditions are starting, whereas class 1 and class 2 less severe conditions are there. Congenital heart disease also we can see that ASD, VSD, PDA, all these are coming here. Gradually there is a congenital heart disease where there is a coarctation, then there is a dilatation of aorta. All these will be coming to more severe grades then. The cyanotic congenital heart disease will go to class 3. Complex heart disease, congenital heart diseases will go to class 3. Fontan procedure, where there is a left-sided atrophy of the heart, and only the right ventricle is now, atrium and ventricle is only functioning with Fontan procedure. That congenital heart disease, which is a very complex situation, that will go to class 3 or class 4. Thank you so much. References are from, I have taken mainly from Williams Obstetrics and Areas High Risk Pregnancy 2020, and I have gone through many of the articles and especially the figures from the internet to understand the various conditions and to share that knowledge with you. Thank you once again.